Hello. Initially, I am thankful for being here with everyone that is part of this AFINet conference network. I would like to thank especially the chair Alicia Ventura and Annie Wattiker for being in this session. I am Cassandra Borges Bortolon, AFINet trustee, and I work as a psychologist and a researcher in Brazil. Just a minute, I am sharing my presentation. One minute, please. Fechar. Okay?
Okay, we can see that.
Okay. Thank you, Richard. My presentation is evidence-based information and motivational intervention for Brazilian AFMs. Introduction. In Brazil, there are 12 million people affected by alcohol and other substance misuses, and there are over 2, 3, even 4 family members affected. Information deficits. In this context, a wide information deficit occurs for both the misusers and their families. There is a lack of good and accurate information. On average, it takes approximately 3 years for the AFMs to seek help for the substance misuse related. Besides that, only 1 person out of 7 receives treatment. Global burden in AFM's health. Having a family member with alcohol and other substance-related problems contributes to the global burden on family health. However, that impact is still neglected. This impacts emotion and financial health, well-being through task overload, overconcernment, tension, and stress. Aiming to attenuate this information deficit and to increment specialized care, we developed a support program for AFMs called AccuraTech. It is to provide an environment that connects qualified professionals to help for AFMs. Our aim. AccuraTech was supported by founding centers of research and entrepreneurship in Brazil. This is our website. Here you can get to know a little bit more about our virtual assistant named Flora. If you click here, you will be able to contact AccuraTech through WhatsApp. Here is our psychologist team. Evidence-based protocol method. 1 minute, please. One, evidence-based protocol related to information and motivational intervention for families, FMI. 2, hybrid model, provide orientation and information virtual assistant. Flora, psychology counseling. Our program method 1, evidence-based protocol. Our program was built upon, first, a rich database which is experience of families that have sought help in previous care center program, Federal University South Brazil and federal government for over 10 years. Second, it was made of data mining about questions and answers of previous service about what the family really needs. Thirdly, those questions and answers were made clearly and directly in order to be used in the future as artificial intelligence. Finally, in our Accuratech database, there are 900 questions and 900 answers about the different substance misuse, acute and chronic effects, such as what should I do when my son, daughter, in crisis? How could I identify if my husband is high? Our program method 2, hybrid model, provide orientation flora. Information regarding to drug abuse and how the family can deal with its misuse. It is free of charge through an online chat named Flora. Therefore, Flora utilizes our database to provide initial counseling to AFMs. Hybrid model 2.2, psychology counseling by motivational intervention for families, MIF. After the contact of AFMs with Flora, and if AFMs are interested, the next step is motivational intervention for families conducted by a psychologist. Our psychologists have training the protocol MIF. Our programs, motivational intervention for family, was based on stages of change, motivational interview, telemedicine, MIF in order to minimize the impacts of living with a loved one that misuse substances. I will briefly present the target of each session. Session 1, psychoeducation. Session 2, understanding. Session 3, motivational stage. Session 4, preparation stage. Session 5, action stage. Session 6, action staging 2, checking on the planning. Maintenance stage, with 3 different moments of follow-up. Preliminary results, our business model. For whom? AFMs. What? Our value proposition is to provide an environment that connects qualified professionals to help for AFMs. How? Key activities: connect AFMs to experts, psychologists of the area, connect psychologists to AFMs, offer orientation and information based on evidence, provide continuous training. How much? Cost of physical and staff structure. Revenue stream: psychologist, supervision, continuum training courses, subscription of professionals, partners, donation, sponsorship. Continue preliminary results, rich database, fluxograms development, hybrid model, recruitment and selection of psychologists, psychologist service provision. Training for our psychologists and MIF. Training for our psychologists in stages of change, motivational interview, family therapy, and step-by-step of MIF. Development of Flora dialogue script. It was developed a clear and direct dialogue script to Flora to be accessed in WhatsApp. Next step, aiming for the development of the artificial intelligence tool. External validation of our database with AFMs. Some AFMs model were invited to visit a Curartech site in order to get in touch with Flora, to talk about their concerns related to sundowner. After, they would tell us how their experience was. There was positive feedback. Family counseling. There are some AFMs being followed by our psychologists. Moving forward, keep helping more families with orientation and information with our evidence-based intervention. Get more funding to develop the artificial intelligence tool. Have more partners. Reference that I used. There are some members of our team. Thank you very much and a great conference.
Thank you, Cassandra. That was wonderful. It's amazing to see AI and technology being used in this very novel way to help affected family members. So thank you for this incredible work. It looks like there's a question in the chat from Candace. So is the psychologist service fee for the AFMs? I think you should say, is there a psychologist service? Oh, sorry, is the psychologist service free for the AFMs? And if so, is the service funded by the donors and partners alone, or are there other funders? If it's not free, what are the costs and what are the access challenges for people in low resource communities who are often overlooked? So basically, is the service free for AFMs, and if it's not, how are those in low resource communities able to access the service?
Okay, 1 minute, please.
Sure.
1 minute. Chris, please.
Hello.
Hello, Chris. Eu quero comentar que a parte da informação ela é gratuita, information é gratuita, tem um custo reduzido, os atendimentos por psicólogos.
Então, vamos por partes, senão é muita coisa, pode ser?
Claro.
Hi, hello. I'm helping Cassandra here in the translation, and she's answering me that part of it is free, the information is free, the consultants is free, and what else, Cassandra?
Counseling, o acompanhamento por psicólogos tem um custo, mas é um custo um pouco mais social, assim.
Yes, the counseling has a specific rate for a fee, but it's not so high. They try to reduce as much as possible, but it has this cost.
Tivemos apoio de centros de pesquisa aqui do Brasil e nesse momento estamos abertos para outras, né, parcerias, enfim, porque precisamos desenvolver a plataforma de inteligência artificial.
As the next step is to develop the artificial intelligence, they are counting on the support of some research centers, and they are open to have more members, more people to help them.
Excellent. Thank you very much for answering that question. I see that Maxine Lacey has her hand up.
Sorry, I hit that button by mistake.
Oh, okay. Does anyone else have a question? Jim Orford.
Dear Cassandra, thank you very much for your talk. Very much appreciated it. This is a slightly cheeky question, but you estimate that there may be 30 million people in Brazil who are affected family members. How many of them do you think you are reaching at the moment? And how many do you think it's possible to reach with the methods you are using?
Cassandra, você entendeu?
Eu entendi que tem 30 milhões, então, afetados no Brasil. Ele perguntou se aumentou?
Não, ele perguntou, desses 30 mil, quantos você acha que está atingindo? E, se não está atingindo, qual que você acha o potencial? Quanto você acha que é atingível? Através do método que vocês estão usando.
A gente se tem uma expectativa de atingir, né? Porque são diferentes classes sociais também. Então, assim, eu gostaria de atingir essa população. Ainda temos algumas pessoas atingidas, e com a implementação da inteligência artificial, né, que pode ser todos os dias, todo momento, nós teríamos condições de atender toda essa população, e a partir que a gente divulgue mais, enfim, e tenha mais apoiadores, até aumentar esse apoio. Thank you, Jean, for question.
Então, ele só queria saber uma coisa, se você atinge quanto, que foi a pergunta? Pouco ou a classe social qual?
Independente da classe social. Eu acho
Isso,
que a gente
pode... Você consegue falar?
Ainda a gente está limitado pelo WhatsApp. No momento que a gente for para a inteligência artificial, a gente vai poder realmente atingir essa população que é tão grande aqui no Brasil.
Yes, so by the time she cannot tell exactly how many people they can reach, because it's only through WhatsApp. She's waiting for more sponsors, more funding, and to make it bigger in order to develop the artificial intelligence. With that, she thinks it will be much more reachable, it will be much open for everybody than nowadays is.
Wonderful.
And I asked her about the percentage. She cannot tell exactly how much the percentage of reached people, but she thinks in the future will be reachable for many more.
So there's a request here. Could you share a paper on the development of the chatbot, as it would be interesting to replicate this, but also perhaps apply five-step train support? Is there a paper available about the development of the AI?
Se você tem algum slide, algum documento, né? Um chatbot
Uhum. Ainda não.
Unfortunately, not yet. She hasn't had yet.
Okay, wonderful. Well, we will.
Sorry, I will ask another question to her. Mas você não tem nada que eles estão pedindo, não se você tem.
Sim,
Para
por exemplo,
compartilhar.
so I have a lot of materials about this project and the program. I will share. Yes.
Great. So it would be okay if people contact you, get that
Okay.
information. Fabulous.
Thank you.
Well, thank you so much, Cassandra. This was a wonderful presentation. I am told that I have to adhere very strictly to the time guidelines. Gal's giving me a thumbs up. So we're going to move on to our next fabulous speaker, Anne Whitaker. And Anne is a professor and clinical academic in applied alcohol and drugs research at the University of Stirling in Scotland. And Anne will be presenting on preventing drug deaths, affected family member views of the role of, on the role of primary care. Take it away, Anne.
Thank you, Alicia. And I'm just going to share my screen with any luck. I'll get up my presentation and you can let me know whether you can see that or not. Good?
Yes, we can see it. I don't know if you want to put it into the full.
Yeah.
There you go. Perfect.
Good, good. And I've just lost it then. Oh dear. Hold on. I've clicked the wrong one. How do I get rid of that? How do I actually see it? Gallery at the top. Right. Okay. So thank you for asking me to talk and present some of the findings on this research study. Just to start off, I wanted to acknowledge the research team that worked on this project. All the names of the people are on the left-hand side there. And I just wanted to start by giving a little bit of a background to why we did the study and how it came about. So in terms of drug-related deaths in Scotland, we have a very high rate of drug deaths in Scotland, the highest drug-related death figures really in the whole of Europe and indeed the whole of the UK. Other areas in the UK, drug deaths are increasing. But there have been particularly high rates of drug deaths in Scotland for a number of years. So it's a big concern here and a big, kind of public health crisis, really. Most drug deaths here are attributable to opioid use in combination with other drugs, often benzodiazepines in Scotland. So we have drug treatment in Scotland is delivered mainly through the National Health Service, and we have specialist drug treatment services that deliver medication-assisted therapy, opioid replacement therapy, and the GPs, primary care teams, are quite involved in the delivery of care, and including drug treatment in Scotland. And we have what they call a National Enhanced Service contract for drug misuse that the GPs and primary care teams can sign up to. So quite a lot of them are prescribing medication-assisted therapy. The model of care here for drug treatment is what we call a shared care model. So specialist services working in collaboration with GPs and primary care teams. In Scotland, we have most of the GPs who are involved in drug treatment are in what we call deep end GP practices. That's the 100 most deprived areas in Scotland where the GP practices are situated. So for us, though, very little was known really about the role or potential role of GPs in Scotland in terms of the prevention of drug deaths and drug harms. And a number of years ago, the Scottish Government set up what they called the Drug Deaths task force, which was leading on responses to try and improve the prevention of drug deaths in Scotland. And in 2019, the Drug Deaths Task Force funded 10 research projects, and this project was one of them. So the aims of the project was to explore models of shared care, to identify good practice and what we called leverage points in the system where we might improve practice, analyze stakeholders' accounts of what worked and what doesn't work in the context of primary care, and to consider the impact of COVID-19 as well, and make some recommendations in terms of future policy and service provision. So this study was really a qualitative research study, and we took an in-depth case study approach. We chose two quite different deep-end GP practices in Scotland, one in England and one in Glasgow. We took a kind of what we called a complex systems thinking approach. So we tried to kind of map the model of care and the system of care of which GPs are part of. And we selected interviews with key stakeholders. So that included patients who are drug dependent, registered at the surgery, family members also registered at the GP practices, the GPs themselves, other practice staff, and other key professionals, for example, specialist drug treatment providers, policymakers and commissioners of these services as well. We also then followed the interviews up with some focus groups to explore with the mix of stakeholders, explore the model of care in each area and what was possible in terms of improvements. And we presented the preliminary findings to a wider stakeholder group to discuss the findings and agree ideas around what recommendations could be made. So this is just a very brief overview of the two case study sites. One was a very large GP practice, the other one was slightly smaller, in fact considerably smaller, half the size. Both were prescribing practices, so they were prescribing to drug-dependent patients. They had a multidisciplinary team. One practice was more experienced, really, and was prescribing to, including same-day prescribing for people with opioid dependence. And one practice kind of fitted in their normal drug dependence work into, you know, their normal patient system. So drug users would just book in an appointment with their GP like everybody else. And the large practice had a very good kind of partnership arrangement. They met regularly with all the other services and worked together on identifying high-risk patients and how to meet their needs. The other one had what they called a shared care clinic. So it was a special clinic in the GP practice where all the drug users turned up on a particular day, once a week, and the GP saw them all at the same time. They were meant to have a specialist social care worker working with the GP in the clinic, but the whole time during the pandemic, that specialist worker was not available. So it was really just the GP delivering the service on their own. So what I'm presenting here is really the findings that relate specifically to affected family members. We interviewed a number of affected family members. We were particularly keen on including those who had lost someone to a drug-related death or had experience of multiple overdoses. And we also asked all the professionals about their inclusion and involvement and the kind of support they offered to affected family members. So here I'm just kind of summarizing some of the key points. So the majority of the affected family members who attended the primary care practices had a loved one with multiple morbidities and very complex needs. There was kind of stress that it was very rare to have someone, you know, who just turned up with problems related to drugs. Often they had multiple problems, particularly severe mental health problems. The affected family members were often local people born and brought up in the area, and the whole family often were registered at that practice and were well known to the surgery. Most affected family members were well aware of the drug death risk, and some of them talked about dreading that kind of knock on the door where the police might turn up and tell them that their loved one had died. Many obviously had lost loved ones. They're usually their sons or daughters. And they all talked about the kind of high level of stigma, social isolation that they experienced as a result of being a family member whose loved one was a drug user. The affected family members often were, when we talked to them, more concerned obviously about their loved one's well-being than their own. And many reported pretty poor health themselves. So, poor physical health and mental health. The affected family members reported quite varying experiences in terms of quality of care, both for themselves and their loved ones. And the GPs also reported varying degrees of engagement with family members and varying degrees of awareness about the kind of nature of their circumstances and the needs that they had in their own right. Often affected family members presented to the GPs with stress-related conditions. Sometimes they were requesting sick line to get time off their employment, or they talked a lot about turning up, attending the surgery to get help for their loved one. Most needed help to navigate very complex systems of care for their loved one, especially in relation to mental health care, but also, homelessness, criminal justice issues, etc. Most affected family members reported little or no help for themselves. However, some said they were well supported by the GPs and the primary care teams, and some also indicated that they didn't want or they didn't need help for themselves. So some GPs referred affected family members to local family support services, and some GPs were totally unaware of these services and their existence. One of the practices was providing take-home naloxone to family members and teaching them how to use it, and the other wasn't and hadn't actually considered it. There was significant levels, as you can imagine, of loss and bereavement in the affected family members and in the wider communities in which these GP practices were situated. So what I've got here is a couple of excerpts from some of the participants, just to read through their story and to give you a sense of some of these key findings and how they emerged. So one of the affected family members was a mother called Nettie. Now, I have done a good job of trying to take out all the Scottish words in this excerpt, but there probably are some Scottish words that nobody understands. But anyway, I'll read it out and see how we go. So Nettie said, "I'm in my 70s. I was born and brought up here. I've always been registered here, but I hardly ever see the doctor. If I need a doctor, I just take anyone. The last time I seen my doctor was last year. My son was in prison and he was getting out, so I come to see the GP to talk about my son's psychosis. I says, look, he's getting out of prison and I need you to give him some help to make them aware. I says, can I bring him in to see you when he gets out?" Which was good, and that's what she did. My sons started taking drugs when they were young, I'd say about 14. My older son, Bob, was the one that started the ball rolling, and then he got my younger son into it. They've been on drugs all these years, and I believe that's what killed Bob. Eventually, that's what the reason was. Tony, my younger son, was fit, really fit. I was shocked with Tony when he died, but they were both amazing sons. Over the years, they took all different drugs, and life was, at that point, she became quite tearful. There was help out there for them, but there wasn't any help for me to deal with it. There was nowhere I could go to get help. There was nothing. Bob's CPN, the mental health and addiction nurse, was amazing. They said, you need help as well, but I'm still waiting on that help coming. So it's plenty help for addicts, but not for families, because the whole family goes through it. I mean, it affected not only me, but my sister. They didn't want my sons down at their house because they were drug addicts, and I totally understand that. So it's like you're shunned because you've got an addiction. They were on drugs for years and years till the day they died. I came in with Tony to see his CPN and GP. I sat with him a couple of times till he got his methadone, but that was where it ended for me. There was nothing there to help me with it all. Bob came in and got his methadone too, and he was fine on that. He was stable, but both of them were taking street Valium. But it got to the stage where Bob, he wasn't able to swallow his methadone for 6 months before he died. He could hardly take any. He was that ill. So the researcher says, what about yourself? What were you expecting? The mother says, I just wanted a miracle. What mother doesn't? I just wanted some help, and there was nothing there. Nobody for me to talk to or to explain how I was feeling. At that point, she became tearful again, and I never got it. But I don't think it would have changed things. It would never have changed things anyway. What happened, happened. It was going down that road anyway. So whether I got help or not, that was always going to be the outcome. I knew it. Well, you needed support for yourself too. Well, that's what I mean. And there's just not just me going through this, especially in this area. I don't know about other areas, but every area's got it. I believe each mother and father will tell you there's support for addicts, but not for the parents or the siblings that are in it who's seeing this. It's not nice. They died in their 40s just last year, a couple of months apart. What do you think would you have needed? What would have been good for you? I would have loved a CPN to come and give me help, same as Bob was getting. Just somebody there to talk to offload. Just somebody else to understand where you're coming from and what's happening around you. Like there's nothing like that. I mean, now I could speak to people. She's referring to bereavement counselling. I tried it here in the surgery with the mental health addiction nurse. Once I tried it and I thought, that's not for me. I thanked them and I says, I'll not be back. So talking to someone didn't work for you? No, it didn't, no. I think it's too soon, she becomes upset. Apart from speaking to you or the GP over the phone, I don't let anybody talk about my boys. I don't allow it. I haven't even grieved. I know I have my tears, but I've not grieved. And I don't know why. I think by talking to someone, it means I'm letting go. And I don't want to let go at the moment, if that makes sense. I'm not ready yet. I suppose there is something out there for me, but it's my fault because I don't want to speak about it. My GP's been great. I phoned up and said, I need you to tell me now he's not here. Did you know Bob was dying? And they says, Nettie, I would have prepared you if I'd known. I believe in preparing people. I believe in preparing people if it's going to happen. I trust them and I believe them. But it's something I had to ask. They're a great doctor, highly regarded in this community. She then went on to talk about her son's deaths. The researcher says, had they had previous overdoses? And she says, no. I would know what to do because Bob taught me. He said, listen, if anything happens to me, here's a naloxone pen. Bob always kept one because he thought it was going to happen to Tony, and Tony thought it was going to happen to Bob. They watched out for each other, and Tony told me the same thing. They taught me what to do. They had it in their bedside drawer, the naloxone pen, where I could get it.
And I hate to interrupt now because this is so moving and fascinating. We are a little bit past 15 minutes, so I'm not sure how to proceed. Okay, sorry.
Do you want me to read these and then just go to the end? Or just go straight to the end?
I think going right to the end might be helpful, yes.
Okay, so I'm going to pass over those two and the GPs. So I'm just going to say some of the kind of recommendations from the study in terms of focused on affected family members. These aren't all the recommendations, but one of the key messages that came out from pretty much all the stakeholders was around designing services and designing them with all the kind of key stakeholders, and designing services that are, you know, what they thought was co-designed local services. So there's too much being done where people quite removed from local communities were designing what service was suitable for that local community. So we've made a recommendation about involving patients and affected family members from registered practices in local communities to co-design their own services. We also made a recommendation about building on the strengths. There was lots of good practice, so building on good practice and trying to overcome the barriers that were evident. Most people were pretty clear that they knew what the problems were. So that was another recommendation. And then it was all this idea about moving from individual-based models of care to more of a kind of whole family support model where people might get individual one-to-one work, but it was more assessment and response to the whole family. And then the other thing people talked about a lot was reframing the problem. So instead of saying it's a drug problem or it's a problem of drug users, shift that and think about it being really a problem around services and service availability, acceptability, the quality of services, for example. And lastly, just kind of thinking about, you know, what does holistic care mean? And, you know, taking into consideration the families and in particular family relationships and the needs of the kind of whole community in which they live. So that's me.
Thank you, Anne. That was a fabulous presentation, very comprehensive qualitative study. And I very much like the multi-level approach that you took. We are out of time. So I'm wondering if it'd be okay with you if you wouldn't mind chatting your email into the chat, and if it'd be okay if folks were able to email you questions. That would be okay? Okay, great. So with that, we will now be taking a 15-minute comfort break. And when we return, we will have a session that will be chaired by Jim Orford. So thank you very much, Cassandra and Anne. Those were absolutely fabulous presentations.
Yeah, so again, also many thanks to Alicia, and we'll meet again in 13 minutes.
Oh, I'm sorry, 30 minutes.
30